Welcome to our lunchtime symposium. The time is now to prevent HIV. I'm Jody Jollimore. I'm your moderator for today. I'm the Executive Director of CATIE, Canada's source for HIV and hepatitis C information. Before we get started, I'd like to acknowledge that this symposium is taking place on the traditional lands of the Anishinaabe, the Haudenosaunee, and the Anawandran peoples, on the lands connected to the London Township and the Sombra Treaties of 1796 and the Dish with One Spoon Covenant. If you've been through a land acknowledgement with me before, you know that it's not just about acknowledging the territory for me. It's about recognizing that Indigenous people in our country are disproportionately impacted by HIV, hepatitis C, the drug poisoning crisis, and so it's imperative that we center them in our work. We're going to get started with our panel today, and I'm going to ask our presenters to introduce themselves, and I'm going to start with Dr. Sarah Stone.
Thank you. My name is Sarah Stone. I'm a family physician. I've been taking care of patients with HIV for the last 20 plus years. And my practice consists of HIV prevention and HIV treatment and primary care. And I'm also the medical director of HIV for Vancouver Coastal Health Authority.
Thanks. And Mia.
Hi everyone, thank you so much for spending the lunch hour with us. My name is Mia Bionde. I'm trained as a primary healthcare nurse practitioner. I practice in primary healthcare and have focused practices in HIV prevention and viral hepatitis. And I'm an assistant professor at York University on the research side, and then I'm the program coordinator for our NP program. So it's really a privilege to train new folks, and we definitely talk about HIV prevention.
Thanks. And Andrew.
Hi. Sorry. My name is Andrew Bui-Nguyen. I'm a family physician in Montreal. I work in a sexual health clinic, HIV provider, and I work in a rural hospital in the Laurentians in Quebec in an ICU setting. I'm interested in sexual health and substance use disorders, as well as psychedelics therapies.
Thanks, Andrew. And Grace.
Hi, everyone. My name is Grace Chiutsi. I work with the AIDS Committee of Toronto. I'm the Women's Program Support Coordinator. I work with women living with HIV, and I'm a woman living with HIV as well.
Thanks, Grace. I realize I jumped the gun with introductions. I was actually supposed to go through a few logistics with folks first, but we'll take that on now. Throughout the symposium, we have some opportunities for you to engage with us. We're going to be doing some speaking, but we hope you will take part in our polls and word clouds. So you'll notice that there is a QR code both on the screen, and there should be some on your table. I would invite everyone to use your smartphones to scan the QR code now. There will be a couple of opportunities to engage throughout the presentation. I will remind you again later for folks that are just coming in, and the QR code will be up again, but if you're prepared, then we'll be able to get started quickly. We'd like to thank ViiV Healthcare for their support of this symposium. The content was designed and developed by our expert panel, and it's for educational purposes and discussions. These represent our individual views, not that of ViiV Healthcare. We've already gone through our introductions, but here's a list of where we all work. And I also want to mention that our panel was quite aware that with rising rates of HIV in provinces in the prairies, that our panel does not actually have anybody from the prairies. So we sought out some expert advice from Dr. Alexander Wong, and actually several of our panelists also spoke to their colleagues in the prairies to get a sense of the pulse of what's going on there. These are our disclosures. And next I want to talk about our objectives. So today we have some ambitious objectives, and we'll be taking you through a discussion of regional trends in HIV epidemiology across Canada before we explore the role of prevention, specifically PrEP, in reducing HIV transmission. Throughout, we'll discuss potential opportunities to improve HIV prevention and identify pathways to overcome obstacles for optimal PrEP use. As I was saying in our preparation for the panel, we have a very knowledgeable panel here, so I think we're going to have a good discussion, and I hope you have some good questions for them as well. So now I'm going to invite Sarah to start us off with our first set of slides, which will walk us through some national and regional trends in HIV to help us situate why it's important that we talk about prevention now.
Thanks, Jody. So this first slide is really just talking about the PHAC surveillance data around HIV incidence. So the infection rate so new infections per 100,000 people. And if you look, you know, the description of a 24.9% increase in incidence from 2021 to 2022 reminds us that new infections are still happening and that it's still important. But when we generalize that number across the country, it ignores the fact that the epidemic is very different province to province, as well as the new incidence rates are different province to province for a variety of different factors. And so I think it's important that we always talk about each epidemic in a local region, because that has a bearing on how we intervene in a prevention strategy. And as you can see, the majority of the provinces did show an increase in new infections from 2021 to 2022, except for British Columbia. And then if we layer that, the next part of this slide around the national prevalence data, the majority of people living with HIV still reside in Ontario and Quebec, sorry, back up, and British Columbia. But if you advance to the next slide, I think it's important for us to recognize, too, the impact of new arrivals in Canada on regional incidence of HIV. And so in 2023, we had a surge of asylum claimants with an uneven distribution across the country. So the majority of those asylum claimants, you know, around 144,000 of them moved to British Columbia, Alberta, Ontario, and Quebec. And for many of those folks, their infections may have been diagnosed at the time they arrived in Canada, so the transmission itself may not have happened in Canada. And teasing out that data around new infections and the source or the origin of that transmission can be difficult. Montreal, for example, and Andrew can comment as he's working there, saw a 120% increase in incidence from 2021 and 2022. And that was largely suggested to be due to migratory influence. And the highest risk exposure category for those folks were people coming from HIV endemic countries. And similar sort of statistics out of Alberta. And I know in our practice in BC, we're seeing a large percentage of new infections from newcomers to Canada, not necessarily asylum seekers, but people coming from other countries where HIV has higher, where it's more endemic, and they're accessing healthcare for the first time in BC and are newly diagnosed. Whether the transmission's happening in British Columbia or outside of British Columbia, I think is really difficult to determine. And so if we look at the 90-90-90 targets, and for those of you who are, I'm sure most of the people in this room are familiar with the 90-90-90 being our goals to have 90% of people living with HIV know their status, and of the people who are HIV positive, 90% of them on treatment, and of those who are on treatment, 90% of them are undetectable or have a suppressed viral load. Canada as a whole fell short in the second 90, so of the percentage of people who know they're positive, only 87% were on treatment. But when you break it down even further, next slide please, you're going to see this really varies based on jurisdictions. And in particular, our prairie provinces have some challenges in the second 90 as well as some of the third 90. But I even see within the patient populations in these 90s, you know, for example, my perspective from British Columbia, you've got 94, 92, 95, but I know that folks living in the downtown east side who inject substances have a much lower, I think our number of patients suppressed who are on treatment in the downtown east side is close to 65%. So it's a huge glaring flag, or a group of people that are marginalized, that don't have the same access to care, often don't fall into these 90-90-90 categories, but when you lump them all together, it gives sort of a false sense of reassurance in some of our spaces. But even with all of that aggregate data, we're still seeing that that second 90 is falling short across the country in a lot of places, but in particularly in Saskatchewan, Manitoba, and Ontario and Quebec. Next slide, please. And this speaks to what I was speaking in Vancouver at least, but this is PHAC data as well, showing that marginalized folks or patients that in patients who inject drugs are African, Caribbean, and Black communities have lower second 90 scores, below 90. So we've got 88, 83 to 85%. In particular, people who inject drugs, their viral suppression is down to 63% for people who are on treatment. And then if you look at First Nations communities in Saskatchewan, the question mark is, I think, because the percentage of people where they actually were able to determine their ethnicity was such a low percentage of the total volume that it makes it really hard to make sweeping assumptions around the percentages, but we know that they're disproportionately infected and disproportionately not suppressed. And next slide, please. And then if we look at new diagnoses by exposure category, we're seeing an increasing number of folks living newly infected in our heterosexual category, and an increasing number in injection drug use in some parts of the country, in particular the prairie provinces. But I always struggle with categorizing folks in these ways, because we all know that there are people that have sex, that are heterosexual, or male-to-male sexual contact who also use drugs. And so this syndemic overlaps, and if we even talk about not injecting drugs, using stimulants or crystal meth or things that change sexual behavior such that it's high-risk sexual behavior, that can certainly drive new infections in any sexual manner. So it becomes really challenging for me to separate them in these concrete triads. Next slide, please.
Thank you. We're going to turn it over to our panel now and ask folks to unpack some of that data and what you're seeing on the ground locally. Andrew, can you talk to us a little bit about Montreal?
I forgot I had
Montreal. Sorry. We do see that there is an increase of cases. The last data we had was in 2022, which counted in Montreal, counted for 310 cases, half of whom were attributable to migrants. But we do see that the categories of people that are represented, migrants, MSM, heterosexual, from non-endemic regions, and injectable drug users, they underrepresent a lot of subgroups. And interestingly enough, half of these diagnoses were made very late in the process with low T4 cells at diagnosis, which comes to my reflection around how all this time elapsed between infection and diagnosis. Where did we focus our interventions, or where could we have focus our interventions? And a lot of the things that we see nowadays, there's higher risk-taking with lower risk perspectives, financial barriers, but most importantly, there was a catch-up after the pandemic, and we see a lot of mental health crisis and substance use. People are engaging more and more casually, I think, in practices of chemsex and sex parties. And one of the questions is, how can we link people to care when they receive a negative HIV result? And I think I'm biased in context where working in a sexual health clinic, we see people, they come in for PEP, for example. We hook them up on PrEP. We're very highly conscious about all these risks and HIV risk acquisition, but outside of this hub of sexual health providers, how can we do better to make people comfortable in seeking that care and getting the prevention tools that they need? I think it's a lot in harm reduction and normalization of the approach.
Thanks, Andrew. We've been talking about Newcomers Canada, and Grace, I know you work with newcomers. Can you talk to us a little bit about what you're seeing?
Sure. As I said in my introduction, that I work with women living with HIV. I focus more on women. I've been seeing so many women coming for programs. You know, Toronto is a big city with different services, so the numbers are increasing. Most people are coming from endemic countries, And for them, when they arrive to Toronto, they see other people, multicultural city, and for them, they get engaged in support groups because that's the only way they can be able to learn about navigating the system in Canada. Because most of the people who I'm seeing, they're in shelters. So when they come to the programs, that's how they get the information to access the services in Toronto. So, but what breaks my heart is all those people who are in shelters, they are not finding homes, and some, they're not getting the healthcare system, and the numbers are increasing. And then when they come to Canada, they expect that when they get here, things, they move so quickly in terms of medication, or you find your diagnosis in Toronto, and then you think you get connected easily, but it's not as easy as that. So I find that ACB community and people coming from Mexico and other countries are struggling by getting the medication itself or navigating the whole city, because the city is a big city. And some people are struggling with language barrier as well. That's what I'm seeing. I can't really focus on negative because I'm focusing on people living with HIV are the people who I see most of the times.
Thanks, Grace. Notisha gave a great presentation yesterday where she talked about folks not being connected to care because of where services are located, and they're often located in places that communities who need them are not. Mia, will you round us out with this section, please? Thanks.
So maybe a little bit on the similar vein in terms of some of the work that I do among asylum seekers. And I would say, as you all know, many people do seek asylum in Canada for sexual orientation reasons and safety. And although folks might come from an HIV endemic country and might have a pretty high level of knowledge around HIV testing and diagnosis, I do find, and I will say especially among women, that the awareness around prevention is absolutely not there. So I think that's a massive gap. There's some intersectionality there, of course. I also do a lot of rural care, and so people are referred to my practice from all over Ontario. And these are places where HIV is not talked about, actually, and providers are not talking about HIV. It might be a checkbox on an STBBI screen, but you wouldn't believe how many providers say, oh, you're not at risk of HIV, we're just not going to test you for that one, we just won't include that. So unfortunately, I actually see a lot of new diagnoses in the context of a PrEP initiation. So these are not PrEP failures, but these are folks who are seeking PrEP and for cultural or family reasons haven't disclosed their preferences to their family, and so just getting healthcare in general is tricky. But then they're going on PrEP, and in the context of that, getting a new diagnosis. So I think there's still a gap there. If I can just end by talking about linkage, I mean, there's some really powerful health systems work we could be doing in this space. One of, as we know, is through our public health units, where there are very few who offer prevention counseling, nevertheless care. And then also, we have a publicly funded point-of-care self-testing program for HIV, and there are not great linkages to negative tests to providers who could provide prevention or services or community spaces where these conversations could happen. Thanks.
We'll remember that for our calls to action at the end. Thanks, Mia. Advances in treatment and prevention have demonstrated that PrEP is an essential component to the prevention toolbox. A lot of my gay men's health career was dedicated to advocating and promoting PrEP. This next section will explore the current role of PrEP in prevention, obstacles to its optimal use, and pathways to overcome these obstacles in the goal of walking a different path to achieve HIV care targets. Mia, I'm going to call on you again to walk us through this section.
Thanks, Jody, and I promise 5 minutes only.
I got you.
So you've all seen an image like this before. This is in the context that PrEP is in a part of a toolbox. These are probably things that, while some communities might know a lot about, other communities might not, and we should offer all of them, and we should offer them often. But we'll just specifically focus today on medication-based prevention. I'll take the next slide. And just this is sort of building on to Sarah's data in terms of introduction, but really talking about, okay, so we've talked about where new diagnoses happen. Now, where are the prescriptions actually happening around prevention? And you can see that, well, we could be really optimistic and say the prescriptions are going up, they're going up in certain communities, right? So they're going up mostly among males, and this data is from either BC Centre for Excellence or IQVIA, and so I have a real problem with all these types of data when we try to make sweeping statements, but just so you know that these are administrative data, so we can't comment on sex versus gender, right? And also that this is not necessarily representative of all prescription data. This is approximately 60% of prescription data in community pharmacies. So again, to be positive and optimistic, saying prescriptions are going up, that's good. Are they going up in the right ways, in the right spaces? We really don't know. We do know that younger folks are receiving the most prescriptions at this time. This slide is speaking to Ontario, and so many of you are familiar with the PrEP to need ratio. And this is specifically, again, among males, and I won't caveat this again around administrative data and all of the problems with administrative data, to show that, well, we might be addressing the PrEP to need ratio among males. It's very unlikely that we are addressing them in the right spaces. We've done some similar work with women, and I think when we look at PrEP to need ratio, it's epidemiologic data that's fraught with problems, right? These are not around self-disclosed acts and risks, and I'll just take the next slide to finish off. And so what's been shown, at least among males, is that self-perceived risk is not the same as objective risk. Does that make sense? So we actually have a poster here in a similar format around women in Ontario. We surveyed 300 women, and it's very, very similar. What people disclose are their sort of daily, weekly, monthly activities do not match their self-assessed risk of acquiring HIV.
Thanks, Mia. We're going to wake everybody up by turning it back to you and asking you to participate in word cloud. The word cloud is really asking what are some of the obstacles to optimal PrEP use. So you'll see here again, we've got our QR code as well as the number that you'll need to log into Slido. Oh, sorry, I think I've skipped over our slide. Here we go. I'll give it another minute or two for people to type in their answers. Obviously, stigma, cost, homelessness, education. I mean, stigma remains number one, which is interesting after almost 10 years of PrEP approval in Canada, that we're still facing stigma with its uptake. Knowledge and awareness. And cost, which I don't know if there's any provincial folks in the room, but cost is still a barrier, and your sector is telling you that. So if you've still got deductibles in your province, you need to work on that.
And I think there's value in saying that if you look back at your slide about the provinces that have the highest prescribing per capita, British Columbia had the highest, and it's the only province with universal PrEP coverage. So cost is a barrier.
Andrew, I'm going to ask you to contextualize some of this for us.
Right. I saw a word, but it disappeared. It was complex, and I think it is truly complex to kind of decipher the obstacles that might lead to proper and optimal PrEP use in our communities. And we've regrouped these in 4 major categories. I'm going to take a more personal stance and views around this because I always find it fascinating how when you take it apart, PrEP is a simple, easy to prescribe tool with easy follow-ups, but then you put it in the context of individual, interpersonal, cultural, social framework, and it becomes a very complex thing to navigate. On an individual stance, you have self-perceived risk, self-stigma, The fact that I'm taking PrEP, I feel like I'm being promiscuous, I should not be doing that. Not wanting others to know that you're on PrEP, depending on cultures as well, and feeling like you're being outed for that. And that relates to your interpersonal experience with this. And on a more personal note, this is what I was gonna tell everyone, but my mom found my PrEP one day, and she thought I was HIV positive, and it led to a very interesting talk thereafter. So it kind of tied into that experience. On the other side of things, we have the healthcare professionals. I think we're talking to a room of informed folks and that have a certain positive bias around PrEP. But if we go beyond these communities, I think it's a very difficult thing to have people engage and break their preset values and become aware and gain education around PrEP. And there's a lot of mistrust and structural things in place as well. And we can talk about the more higher structures, how there's sourcing for that, there's financing for that, how our governments are if they're funding for that or not. And copay is a huge barrier to PrEP. Can I get the next slide?
Yeah.
This is to focus more on the healthcare side of things, and I'm going to tell you another story. When I was a resident back before 2016, which is a long time ago for me now, I'm not a baby doctor anymore, but I did a presentation on PrEP right before the Quebec guidelines came out, because I was interested and because it was something that I was fond of. And 50% of my attendings when I did the presentation kind of were baffled, were kind of shocked, and it led to a conversation of, well, are we going to enable people to have unprotected sex with multiple partners? And back in the days, I was a bit like shook because I was a tiny resident. I didn't want to take too much space. I didn't want to be vocal about it. So I didn't counter argument or anything like that. I just took it as is. But in retrospect now, with the more experience, I feel like it was the same reactions that people might have had in days where contraception became a thing, and then they had the same stigma and judgments around that. And I think it comes a long way to say how our own communities can create that barrier to care and delays in providing these tools to people.
So we'll ask our panel to respond to some of that. And first up, I've got Mia.
So just to start off by saying, you'll see that this is a group of non-specialists, and I think that's really powerful, and I'm in, I think, just tremendous company. Like Andrew, I gave a presentation in the final year of the nurse practitioner program about HIV prevention and PrEP. And I think, you know, when we want these things to task shift to primary care, we all acknowledge the great demands on primary care right now. But that being said, it's truly possible, and I'm actually super proud to say that in Ontario, I'm a part of a consortium of 9 universities that deliver the primary healthcare nurse practitioner program, and PrEP is in there. Right? So we spend about an hour on PrEP, and I know that's not enough, but it's what people need to prime them to go into practice, to know that it's fairly simple and they can use an algorithm and they can get help and support. So I think meaningful integration into primary care, into all sorts of training is really important. And then the other thing I do want to comment on, and it is also health systems related, but we need publicly funded models to drive higher volume of PrEP care, right? We do need it in health units, that's for sure, but we also need dedicated funding streams for non-physician-based models, whether that's nurse practitioner, RNs, tasking, shifting to community workers, whatever it is, these positions have to be funded. And they can't be funded by industry. I think we all know that.
Thanks, Mia. Grace.
As for me, it's different from these professionals who specialize in PrEP. For me, PrEP, I don't think the women are quite aware of PrEP. Women, they don't talk of PrEP, and women are not included much in this PrEP. And besides that, I don't think health professionals share the knowledge or the idea of PrEP as a prevention. So for women, most of them, they think PrEP, if you are taking PrEP, some they think people think you are HIV positive. They don't know that it's a prevention. So we need to see more so that we don't have barriers when women have knowledge of it. What is PrEP? And it comes with so much stigma to women to say, okay, I'm taking for not getting a baby, my prevention for not getting a baby, then taking PrEP as well. It will become too much for them. But when they have the knowledge, they have a choice to know that, okay, there's PrEP, I can take PrEP with my own choice, not that I can negotiate with someone, okay, use a condom for me or do this for me. But they will have an idea that PrEP is there for everyone. And they have to know that there's a cost on PrEP, but they are not getting all this knowledge. And what we forget when we design these things, we think one size fits all, but we have different cultures, we have different people on different levels of education. So if we are doing this, we have to engage everyone in the conversations. I find out gay men have succeeded in so many things. We come to HIV, they have succeeded. We come to PrEP, they are succeeding. So I wish they could help us and other communities, especially women, to use all these models they use for us and to remember us in whatever they do, not to think of us as a second thought. They do something first, and then later on they'll come to women. And for the women, you have to scream all the time, like, we are here, please see us. So I wish if we could have more knowledge of PrEP for the women, that will limit the stigma for us.
Hear, hear.
Thanks, Grace. Andrew, do you want to comment?
That was a hard follow. I do think that there is ways to facilitate PrEP by reducing all of that, emotional stigma. Some of the things that I've seen within our province, self-testing clinics offering PrEP services, they're not always, widely known, but they are there. And from what I know from my peers, they're not, publicly funded. So there are initiatives that can be fueled into and invested in. And I think it's a matter of surmounting that barrier, that reflexive barrier to providing PrEP and seeing it as a difference to any other intervention in preventive health. And it's a matter of mentalities as well. Even in big cities like Quebec City, which is our provincial capital, we back when I was a resident, there wasn't any PrEP services, and Montreal was really lucky to have all these clinics offering services, sexual health clinics offering PrEP, but there was an ID specialist that was still in residency that I talked to, and he was like, oh, I'm gonna start a PrEP program in Quebec City, and I'm like, isn't there any that's family medicine run or something like that? Because it's kind of like using a second, third line specialist to address something that could be addressed in first line. So that contrast was quite shocking to me, and it still remains that in rural geographical areas we have difficulty to raise awareness and raise services there as well. So that's one of my observations.
Thanks, Andrew. Sarah?
I agree with all my panelists, but I'd love to build on what each of them have said, because it brings up some thoughts for me. And Mia's comment about education, I think that we really need to embed PrEP education, HIV prevention, HIV treatment into all aspects, medical school residency, primary care residency programs. And if it's there now, at least in the students that I'm teaching, it's so limited that it feels very new when I'm talking about it with many of my learners. So just for that to be, we have family physicians prescribing all the complicated new regimens of diabetes treatment and cardiovascular risk treatment, and we all know that PrEP prescribing is probably simpler than all of those things, so it should be something that can be embedded in the majority of primary care settings. But that being said, the highest volume of PrEP prescribing, at least in our region, is done in a dedicated PrEP clinic that is publicly funded, and it is able to prescribe thousands of patients on PrEP. but the demand exceeds the supply, so there's a wait list to get an appointment. And if that could be picked up by community primary care, of course, that would make it more accessible. And people travel quite a long distance to come to our clinic, which they shouldn't have to do, or we speak to them remotely. And then to leverage what Grace was talking about, it shouldn't go unnoticed that 50% of the new infections in the prairies are women. And I think that's that all of the socioeconomic barriers, racist barriers, systematic barriers, poverty, everything that is driving the system of care for these women is impacting their ability to access care as well as PrEP. And so I think that when you're seeing rates of infection that high in a group of people, I think we really need to look at how we're delivering PrEP and how we change PrEP access for that group of people.
I think we might have a couple of slides on search that's
Oh, yeah.
for you to present as
For
well.
me next?
Yeah.
Okay.
Thanks.
So I'm sure some of you read this search study that was done in rural Uganda and Kenya, where they took about 1,000 individuals and they offered them, and I think more than 75% of them were women, or no, it was like 60% women, but there was women and men, and they needed to be over 15, have a negative HIV test, and be at risk of HIV. Sorry, over 70% were female. There you go. And the standard of care was to offer them oral PrEP or post-exposure prophylaxis, and the intervention was to offer them a choice of HIV prevention, either injectable PrEP, oral PrEP, or post-exposure prophylaxis. And the intervention was also to allow them the flexibility to stop, switch, change over time based on their own perception of what they needed in the moment. And the results were pretty impressive. With the dynamic choice, there was 70% biomedical coverage, and the standard of care only 13%. So there's like greater than a five-fold benefit to increase biomedical coverage when you give patients the choice. Shocker. Patient-centered care works. And 42% of those who chose the long-acting injectable option were people who'd never been on PrEP before. So that meant that they may have been knowledgeable that that existed, but that modality didn't meet their needs for whatever reason that would be. And then the other impressive feature of this study is there were 0 infections in the dynamic choice arm, and there were 7 in the standard of care arm. And so you can see the age distribution of those that were infected. So I think that just really speaks to ensuring not only do patients have the education, or the public and the physicians have the education about what PrEP options are available and how to get them, but that there's a wide variety of choices to engage the most people at risk of HIV in care.
Thank you. We're going to go back to our poll, so if you want to dig out your Slido, the question is, from the perspective of optimizing HIV prevention, how important is it that healthcare providers offer a choice of different PrEP modalities? So I think overwhelmingly very important.
Yeah.
Thank you, folks, for participating. Maybe not a big surprise there. Andrew, can you talk to us a bit more about barriers to adherence this time?
I think it's interesting that it's a very important thing to offer patients because it ties into the whole individual, interpersonal barrier to PrEP use, but also to PrEP use for yourself. Your perception, I say your because people's perception of their risk or their mental health has a lot to do with the way that they take PrEP or if they maintain themselves on PrEP. If there's other difficulties or challenges in their lives, such as substance use, it can also lead to more unstable psychosocial realities. So those are all things that are barriers to adherence, and I think the last question ties into patient choice as well. and empowerment and their implication in the decision-making process. Of course, other barriers to proper PrEP adherence, medication costs or copay. We're talking about side effects. If there's a modality that they can't tolerate, there's a high risk of abandonment. If there's support from their communities or from people around them, there's even cultures where people hide their pill handling and they don't want people to know that they're on PrEP because it is poorly seen, which ties into stigma around the symbol of taking PrEP itself, which ties into the next slide. They surveyed a bunch of people, 1,190 people from BC and Ontario, to kind of assess the level of stigma that they perceive from PrEP. And 6 out of 7 people had intermediate to high intensity stigma, whether it was anticipation in regards to stigma from partners or self-stigma regarding their use of PrEP, or just worries about being outed. And they noticed as well that the higher the stigma, the less chance they were actively on PrEP at time of that survey, which goes a lot to say that patients' realities are at the core of PrEP adherence and use, and all of our interactions around PrEP is based off of our own individual stigmas interacting into each other, and I think there's a lot to be reflected on there.
Thanks, Andrew. I'll ask everyone to take their Slido out again, and thinking about your own experience, whether or not you're a clinician, whether or not you're somebody who takes PrEP, whether or not you're somebody who's promoting it, what do you think the biggest barrier to PrEP adherence is? And the survey says, well, I really hope there's some provincial government folks in the audience today. Cost, followed by PrEP stigma, but cost still remains as the perceived barrier, the largest barrier by the experts in our movement. So I think that, to me at least, we need to add that to our list of calls to action. So. Grace, can I ask you to speak a little bit about the polling and barriers to adherence, what you're seeing?
Sure. In my experience, you can start on the side of the HIV women. Their experience with treatment, it's really difficult. People hide their medication. People skip their medication because they are surrounded with other people who don't know their status. So when I look at PrEP, women have so many things in place for them to take care of, to think of PrEP on the priority list. As mothers, as women, we have to take care of the house. We have to take care of everyone before we think of ourselves. I have to make sure there's food at the table. I have to make sure the house is clean. I have to make sure that I'm working. And there's power dynamics in homes. Men, they still, in my culture, I can speak specifically in my culture, men dictates everything for the house. Women, you go with what the man says. So as a woman, for you to think of PrEP, how will you present it to your partner? How will you say it? How will you start the conversation? Suppose I'm in a relationship where I'm being abused and I'm trying to talk about PrEP or I'm trying to talk about prevention. Some cultures, they don't talk about sex. Some cultures, they don't talk about STIs. But as I said before, if we manage not to put this PrEP in front of people living with HIV only to talk about prevention, to take it out there, to people who are out there, to let them understand about PrEP, even though they are mothers, But when they get the education piece, to understand about the stigma which comes with all those things and the difference between HIV and PrEP, that will help a lot. But for them to find their way to do it themselves, I don't see it happening. Unless someone has taken action to say we are educating people about PrEP, this is what is happening. Because already, some of them, they don't have housing. All these things, they happen to marginalized communities most of the times. So for them to think of the health, it's the last thing on their mind, to think of PrEP itself. So if we have education piece, that will take us a long way.
Thanks, Grace. Sarah.
So I think about the barriers to PrEP adherence as not universal across the country, because I think access to PrEP, both financially, but also the ease of that is going to depend whether you're in a province where it's publicly funded, if you're in an urban setting where there's lots of prescribers, if you're in a rural setting, if you are homeless and using substances. So I feel like the barriers to PrEP are very individualized, and I'm cautious about making sweeping statements about what those barriers are, other than I will, anecdotally or personally, the individuals getting infected in our region tend to be folks that are marginalized and can't access PrEP for a variety of reasons. Mental health and substance use, chemsex is certainly a big driver in the community of men who have sex with men. And then in substance using folks, it's, poverty, inadequate access to some of the basic essentials, and you've got this hierarchy of competing priorities, and accessing PrEP isn't one of them. And I think that can be discussed across the country in every different region. So I think our calls to action need to be wide and varied and relevant to the communities that we're speaking about.
Thanks, Sarah. Mia?
I'd like to take the adherence discussion sort of in the context of the treatment or PrEP initiation discussion. So also not surprised that people think flexibility is really, really important in choice, and I think that was 84%. I might ask the audience, and maybe we can chat about this in the Q&A, would you answer the same if it was all sorts of folks that could be sitting in front of you? Whether you're in community giving education to women, whether you're a provider, whomever that person is in front of you, whatever risks they have identified or not, and for those of you that know me, know I feel very strongly about this, and it's my personal opinion, but would you answer the same? Would you universally offer all these options and have the person guide the decision? So that's my first sort of question out there. And then, are we being as flexible as possible around adherence? So are we really tied to HIV negative test results, or are we working with our pharmacy colleagues to provide extensions because people are busy? They have we all have a lot going on in our lives, right? And then I guess my last thought would be, there are many folks in this room who also are in the hepatitis C space, and we've really been innovative, I think, in terms of getting medication to people in every way, shape, or form, place, middle of the night, McDonald's parking lot, and we could also try to do this for HIV prevention.
Thanks. I mean, that's person-centered care, right? I think we were talking about this a bit yesterday. This is an HIV room, but we work at other tables, and we're all kind of trying to engage the same folks at this point, right? But we're coming at it from a disease-specific lens as opposed to
views and values, for sure.
Exactly, yeah. Andrew.
I think that patient self-determination and power and agency should be a driver in all of this, to kind of normalize PrEP taking. We went from an era where contraception was the demon to something that is, in my experience, something that is very widely acceptable in our communities. And I know I'm talking to Canadian crowd and whatnot, but I do dream of a day where PrEP is, I'm on PrEP, I'm on LS. It's like, this is like the ad I grew up on when I was young. But I do think that to get to that point, there needs to be more positive discussions around sex and around sex positivity, and about choices that people make, and the responsibility that they uphold in those choices as well. And I think this is something that we can encourage as people that are accompanying these people in their PrEP journey. So this is just my added 2 cents to this whole very interesting talk.
Thanks, Andrew. So we're going to end our session with a discussion about calls to action. So the time to prevent HIV is now. What does that mean exactly? What do we need to get us to our 2030 elimination targets? What do we need to overcome the barriers that we've identified today, whether or not they be around stigma or cost or adherence? What do we need to achieve to optimally present PrEP as one of the tools in our prevention toolkit? So it's time to take out your Slido again. We're going to turn this back to you folks and ask, what are your calls to action? There are a couple of ways to participate. You can either put this into your Slido, or we also have microphones available if people would prefer to just go to the microphone. Either based on what you've heard today, or maybe something over the course of the last couple of days, or just because you're experts on the topic, what do you think our calls to action are?
And we've left 20 minutes for this because we think it's really important to hear from you.
Hi, I dropped this in the Q&A as well, so just ignore that. Mark Fisher, New Zealand. Just we're having the same struggles that you guys are having. We have fully funded PrEP, which is great. Doesn't solve the problem. We're seeing the same issues around barriers, access, people getting into care. Just because they can't, and doctors don't want to do it, and they don't know how to do it, and all these other issues. One of the things, so my question to you is what we're trying to do in New Zealand, is why is PrEP treated differently from the oral contraceptive? So why are there barriers? Why do we have to disclose our sexual history, our meth use, everything else in order to be eligible to access it when it's the same as oral contraceptive and there's less potential for abuse or harm and greater benefit? So why can't we get it into pharmacists, or why can't peers, when they're doing a test with somebody, say, I can get you on PrEP now? I did this where I could give out 10-day starter packs as a peer to people that tested negative because they were presenting with risk. They won't disclose these risks to a doctor to meet the criteria, and they won't even have that conversation. You need to make it easy. So is there a possibility to reclassify down to like a pharmacist level in terms of access? I don't know the rules. So.
Does anybody want to speak to that on the panel?
Andrew?
I'll add to it. For the first thing, I lived in New Zealand for years. I love your country. I think it takes interest to make initiatives that will be perpetuated and then that will catch on to a widespread. And I think, I told you the story about the experience I had when I told my attendings, and I feel like, I'm biased. I'm positively biased. I live in this world where I do believe this is the right thing to do and that this should be widespread as well. And we are in a community where we do truly strongly believe in it. I do hope so. But outside of that bubble, sometimes we have all these, to see colleagues referring patients from rural areas for PrEP, and they drive 2 hours to get to Montreal to get their PrEP, and in the meantime, we lose them because they don't have time to come down to Montreal, and then they get infected and whatnot. I think it comes from very conservative and old-fashioned mentalities that perhaps need to be changed, but changing perspective is such a huge task, and you'll change one person, and there's always going to be, I think, another side of the debate that I'm surprised to see from year to year. There's always new things that pop up. All the anti-trans rhetorics and the anti-abortions and all things like that. I'm always very shocked, because I live in this fantasy bubble that these things are already acquired, but I think we still have a lot of work to do.
Thanks, Andrew. David, I'm just going to read a couple that we've had come in, and then I'm going to ask you. A few people commented in terms of calls to action: publicly funded access to testing, treatment, and care for all, make free PrEP available to women, task shift to nurse-led models embedded in community settings, adding PrEP to the new federal pharmacare program, move PrEP outside of the adult MSM world, ramp up advocacy and action to get universal access to PrEP. We've got a few more, but I want to hear from David.
Really?
Yeah, I do.
Okay. You've heard a lot from me today. So thanks very much, David Moore from Vancouver. So I think, yeah, the answer to your what's the call for action was on your previous Slido poll. It's publicly funded, fully publicly funded PrEP. Like we have in British Columbia, not to say that we've got it perfectly right in British Columbia, but it's clear from the data that Sarah presented and what we've seen in the ENGAGE study, if you provide fully publicly funded PrEP at no direct cost to patients, your uptake is high. There's a poster here from the PrEP program in BC that shows that retention on PrEP is over 80% as far as like more than 3 prescriptions. Again, if you fund it publicly. So that really is the call to action. We did look at, there's an analysis looking at HIV incidence amongst PrEP users in the PrEP program in BC, and the incidence of HIV in that group is lower than the intervention arm in the cabotegravir study. So if people don't have a cost barrier, they will take it, and really, there's a small number of people that will stop using it for whatever reason. Those are the people that actually acquire HIV. It's not people on the treatment. So all of the other stuff is nice and interesting, but really public funding is what's going to make this work. The one other pitch I'll make as far as what's different in BC is routine offer of HIV testing for everyone when you enter a healthcare facility. It's highly acceptable to all patients, and that's how you help identify people that don't see themselves at risk of acquiring HIV, and that really helps the people whose main exposures are going to be heterosexual or use injection drugs, because then they can also find out if their sexual or drug-using partners are living with HIV, and they can then put themselves on PrEP to protect themselves. So 2 pretty simple things, and I think sort of adding too many things to the message can sort of make it more difficult to try and implement what we think is probably working well in British Columbia. Thanks.
Thanks, David. Yeah, I'm going to add something to me. I agree with you, publicly funded PrEP, and certainly, I think that's why we see the uptake. I would argue, and maybe it all flows from publicly funded PrEP, but the fact that there are a lot of physicians in British Columbia that know about PrEP, and there is a very active sort of engagement and education process. So there are lots of points of access too. So I think, there was a highly active community that were pushing for PrEP, and then the center responded with publicly funded, but also a push to actually increase access by having physicians know about it and be willing to prescribe it, showing my BC bias a little bit. Maya, did you want to respond? And then we'll go to the microphone again, sorry.
Just to add one additional thing, if we're moving towards this in pharmacare, if we're moving towards more provincial universal access, I would just make the point that we need to eliminate paperwork. Because while folks in this room might not think the paperwork is a big deal, for novice people that are on the fence of whether or not they want to do this, 10 minutes is a massive amount of time, right? So in Ontario, we have a LU code. It's really helpful. It's really helpful in a lot of different spaces in primary care to get people to do something they might not do. We have to eliminate paperwork across the country to access PrEP.
Thanks, Mia.
Hello. Bonjour, Normand Babin. I'm working for Action Positive, the only organization in Ontario, or at least south of Ontario, dealing with HIV for the Francophone community. We didn't hear a lot of French this weekend, but before talking about PrEP, before talking about those things, we have to realize that in 2014 in Ontario, there was a new government, and they slashed sexual education. We went back to the dark ages of the 80s, and young people then, not so young, below 35, most of them have no clue what HIV is. They have no clue that this is for the rest of your life. So they have no interest knowing about PrEP because they don't know it exists. And they don't know it still exists. And I think that's where we all have to act to force this government to give some information that are actual, that are today. And before thinking about PrEP, they have to know. That's what my call to action would be, you know, education.
Merci, monsieur.
Merci.
Aussi, je veux dire, s'il y a des gens qui veulent commander des questions en français, on peut essayer de traduire aussi.
Good afternoon, everybody. I want just to add what Grace was talking about. Thank you, Grace. I appreciate your role to run and then to empower women in the community in Toronto. So I wrote something before I forgot. To be honest, I think we needed to talk the truth about the PrEP. Some people have a test is positive while on it, so it is also risky, and that's one of the things people fear. If focus can be put on a vaginal ring and the vaccine is good, provide other prevention option, not just a pill. It can be injection, vaginal rings, dually pill, vaccine, and etc. Give women a choices. Providing HIV prevention choice is important. Even include U equals U. As a prevention tools, among other things like the pills, injectable, and the vaccine. But involve peers. I will continue to talk about it. Since yesterday, even tomorrow, I will talk about it. Involve peers to everything if they need PrEP. Uptake in the communities. Have a peer, have a PrEP community ambassador. If really ever think you want. That is a miss. Thank you so much.
Thank you. I didn't catch your name, I'm sorry. Chantel. Thank you, Chantel. So in British Columbia, when we were first promoting PrEP, I was working at a queer men's organization, and so that was our target population. And one of the things we did was we created a PrEP community champions group where we invited people from across the province who were interested in PrEP to come to Vancouver. Dr. Mark Hall, who may be in the audience, was one of our presenters, and we put them through a PrEP school, basically a day-long meeting where they learned about PrEP and stigma and all the different things that might be impacting uptake and access to that. And then we sent them back into their community with a list of activities. And we actually paid these peers to do the work. So we paid them to come, we paid them to learn about PrEP, and then we paid them to go back into their communities to disseminate the information. And they had a list of activities that they were supposed to do. So like one of the things was post on your social media about PrEP in the next week, right? And if they did that, we paid them, I don't know what we paid them, but we paid them an honoraria to do that. And then the second week, they were supposed to put it on their cruising app. Like if they were on Grindr or whatever their dating app was, they were supposed to talk about PrEP there. Or maybe talk to PrEP with a friend or two. And the idea was to disseminate through peers locally who were champions, but also pay these folks to do the work. So I completely agree, and to Grace's point around gay men needing to step up, I think that there's an opportunity there as well. So thank you.
I'm sorry, I don't, I wanted to say, not the honoraria, paycheck, payment, because they work hard, the peers work hard. Yeah, thank you so much.
Thanks, Chantal. I'm going to read just a couple of more, and then I'll, here we go. So some other calls to action that have come in. I think we talked about adding PrEP to the new federal pharmacare, move PrEP outside of the adult MSM world, ramp up advocacy and action to get universal access to PrEP, pharmacist-provided PrEP, also political lobbying, involve public health for access, promote and provide PrEP to women. Women should not be a second thought. What does the panel think about the inclusion of HIV together with other STVBIs? Maybe we'll try to get to that. We've got 8 minutes, but I want to go to our questions. Include trans HIV prevention and combination of gender-affirming care and PrEP. Create integrated systems of HIV prevention. Universal access to PrEP. Why does prevention focus on communities already living with HIV? Are there strategic plans on how best to involve the HIV-negative community? I'm going to do one more. Broaden prevention options to include PEP, fostering healthy autonomy amongst communities. Oh, no, I think that's PIP. I think that might be PrEP or PEP in pocket is what we meant by that. Sorry. To the microphone.
Yes, hi. I'm Wes. I'm with FAC, but I'm speaking right now as a member of the trans community. So you mentioned very briefly the fact that one barrier to PrEP potentially is healthcare providers not determining that their patient is at risk. And David alluded to this a bit as well. I think that this is an issue for many different groups, including heterosexual people and women. But I think for the trans community in particular, we feel it quite a bit because due to the sex hegemony that exists in healthcare, we are often placed in the wrong risk category. So for example, a trans man who has sex with men might be considered heterosexual by their healthcare provider, which really prevents us from being able to access medications like PrEP or different testing services. So my call to action really would be for healthcare providers to really consider more critically think about the risk categories and where they come from and how they've been created, and to think more about things like behavior rather than things like sex, for example, alone. So thank you. That's
Thank you, Wes.
Thank you.
I should note we're taking all of these calls to action down, and there's actually an opportunity at the end if you'd like to be added to the mailing list. We'll circulate them. That's correct, right, David? Yeah, great.
Thank you for the opportunity, and thank you, everyone. My name is Watete Gishuki. I'm with Mark Marster. That's one heart. My other heart is also I work in women's shelters. So to Grace's point of highlighting intimate partner violence as an intersection for women living with HIV. So when we're considering promoting PrEP as a prevention tool, can we also look at PEP and PEEP? Because survivors of sexual violence are not going to be waiting for 72 hours. They're not going to be running to emergency, and they're not going to be reporting. So we still continue to see a lot of vulnerable women without access. So add that into the notes. Thanks.
Thank you. I've got a couple of other points that were shared through the Slido. Broaden prevention options to include PIP. Can you also start with populations that get forgotten in the PrEP equation? International students, migrant workers, and look at PrEP access for all adolescents. Will the HIV self-test or HIV point-of-care test be accepted for prescribing and monitoring PrEP? Option for no minimal phlebotomy as an informed choice. Men have to be educated as well around PEP and PrEP to remove the burden on women, and most importantly, facilitate the conversation on the topic between partners. And then the last one we have is pharmacist prep prescribing is crucial to overcoming barriers related to access. Thank you, everyone, for participating in that. Okay, team, we've got 4 minutes, so I think that's a minute each for a closing remark, unless anyone else from the audience wants to come to the microphone. I don't have to, does anybody want to go first? Closing remarks?
Go for it, Grace.
Go for it, Grace.
Okay. On my closing remarks, for me as a woman, as I said before, I want to see more research focusing on women for PrEP. That will make a difference. It doesn't mean that when we talk of PrEP, we are forgetting us PHAs. We don't want to put the burden on PHAs to keep on talking about themselves, disclosing all these things to everyone. It's everyone's role to take care of themselves, but more research for PrEP for women.
Thanks, Grace. Andrew, you want to go next?
I will advocate for free PrEP and better representation of all subgroups, of all walks of life, of all identities. And I wish that we can have more circles. Like, I think it takes a village to do healing and to uplift a community that might be underrepresented. So I think that's how we will have action in all these points that we're talking about today.
Thanks, Andrew.
In addition to what's been said by my colleagues, and thank you so much for your participation, everyone. So I've talked a lot about health services, we've talked about cost, we've talked about funding, and I do want to give a shout out to the Nova Scotia pharmacist who did present yesterday on pharmacist-led PrEP. It's excellent. And they're working with their college around scope of practice, and this is really important. I think also on the education side is we should really consider if you need specialized training like modules to qualify you to be able to prescribe or care for folks in terms of the PrEP space. We as clinicians need to have the knowledge, skill, judgment. Nobody tests my knowledge if I can care for someone with heart failure, but yet I do, and heart failure is very complicated. So I would just say, let's take away some of these additional things that are put in by government to try to restrict and open up access. And maybe the other big reflection I think my take home is the awareness piece, but it's a whole package, right? It's back to testing, resources around access to vulnerable and many different walks of life. And then I'll end by saying co-localization works. Grace brought it up, Andrew brought it up, Sarah brought it up. We have to embed, offer universally in all sorts of spaces and places.
Thanks.
So I will just, they've said a lot. But I think the other piece for me is that HIV prevention, if you just want to use that category as a whole, is about a system of care. And it starts with testing and routine testing and normalizing testing, which is in itself educational, because I think, if you're being tested routinely at your family physician's office, in your emergency departments, you think, oh, well, this is still a thing. And it's an opportunity, I think, for healthcare providers to normalize that this is a routine part of healthcare. And then the fact that HIV continues to disproportionately affect marginalized populations means that as a system of care, we need to tackle these big issues that are the socioeconomic drivers of poor health. And PrEP is an important part of that, but I think when basic needs aren't being met, it's very hard to prevent HIV.
Bam.
Look
1
at
second
that.
left. Look at you. Good job, team. Thank you, everyone. Please, there's a polls tab in the Slido. We ask that you'd consider filling out an evaluation. We want some feedback, as does Vive for the panel. I want to thank the panelists. I want to thank Vive and all of you for participating. Have a great day. Thanks, everyone.